Hello, everyone. My name is Dr. Kevin Yun. On behalf of CME Outfitters, I'd like to welcome you to this CME podcast entitled Growth Hormone Therapy in the Pediatric Setting, Early Intervention and the Emergence of Long-Acting Agents. This podcast is brought to you by CME Outfitters, an award-winning, jointly accredited provider of continuing medical education for clinicians worldwide. This activity is supported by an educational grant from Novo Nordisk Incorporated. Again, my name is Kevin Ewan. I am the medical director of the Barrow Pituitary Center here in Phoenix, Arizona at the Barrow Neurological Institute and professor of medicine at the University of Arizona College of Medicine and Creighton School of Medicine. And I'm very pleased to be joined by my colleague and good friend, Dr. Bradley Miller. He is a professor of pediatrics and director of the Division of Pediatric Endocrinology at the University of Minnesota Masonic Children's Hospital in Minneapolis, Minnesota. Welcome, Dr. Miller.
Thanks, Kevin. It's a pleasure to be with you and join you for tonight's program.
Good to have you. Let's begin by reviewing our 3 learning objectives. After participating in this activity, learners should be better able to implement evidence-based guidelines for the diagnosis of growth hormone deficiency in pediatric patients. Learning objective 2, interpret safely and efficacy data for once daily and once weekly growth hormone therapies. Learning objective 3, apply evidence on the relationship between growth hormone therapy adherence and outcomes to patient counseling practices and treatment decisions for pediatric patients. So for patient case 1, Dr. Miller, why don't you just take us through this case and discuss the key issues that go along the way with the management of this patient?
I'd be happy to. So what I'm going to present is a case of a 4-year-old girl named Maya, who was the smallest in her preschool class. Her classmates were treating her like a baby. Her 18-month-old sister is nearly the same size as she is, and they actually share clothing. And people think that she and her sister are twins. Her primary care provider recognized a potential problem and referred her to a pediatric endocrinologist.
Thanks, Dr. Miller, for introducing patient case number 1, Maya. So after listening to her presentation and her clinical history, what actually are the psychosocial impacts of being short that could actually have an impact on a patient like Maya moving forward as she grows up?
So I think it's actually one of the main reasons that children are identified as having growth failure are the parents' recognition of the psychosocial impacts of short stature, including, as was mentioned for her, being considered the same size as her sister and thought to be a twin, being infantilized. We see it in boys and girls as they approach middle school and are having difficulty related to sports or being included in sports, teasing and bullying. And I think those are a big part of the everyday impact that growth failure has that may be identified as growth hormone deficiency as its cause.
Yeah. That is certainly not a pleasant situation to be in. I'm sure growing up in that situation. So perhaps Dr. Miller, you can tell us how Maya was eventually then referred over to a pediatric endocrinologist.
Absolutely. So when we think about when she came to see the pediatric endocrinologist, she was shown to be quite small. Her height was actually, as I mentioned, similar to the size of her 18-month-old sister. So she was 85 centimeters at 4 years of age, which would be more than 3 standard deviations below the normal curve. She was also, her weight was relatively spared, which we often see in children with growth hormone deficiency because there isn't a malnutrition problem, but a problem actually using those calories to help with growth. And aside from that, children typically have a normal physical exam, normal initial laboratory testing to screen for common illnesses, including CBC, liver functions, celiac screen, and sedimentation rate. The screening test that we typically use to identify growth hormone deficiency is IGF-1. And in Maya, it was quite low at 36 nanograms per mil, or minus 2.5 standard deviation score. Her bone age was delayed, which was more consistent with her height age at 2 years of age. And when she had a sedated MRI, it actually identified an ectopic posterior pituitary with anterior pituitary hypoplasia that helps to explain the reason behind her congenital growth hormone deficiency.
Great. So how was she confirmed to have growth hormone deficiency, Dr. Miller?
So in addition to the history, the clinical pattern, the screening tests with the low IGF-1, she underwent a growth hormone stimulation test combo with clonidine followed by arginine. And the peak was 2.3 micrograms per mil, showing that her growth hormone secretion is impaired. Because of her ectopic posterior pituitary gland and the identified growth hormone deficiency, she also had her other hypothalamic pituitary axes evaluated and had normal thyroid function and a normal ACTH stimulation test to confirm that she did not have central adrenal insufficiency.
So based on these testing results, so what should be imparted to the patient in terms of the diagnosis and the implications of her health moving forward for Maya?
So I think the importance when we think about evaluating growth is that we've gone from short stature, which many consider to be social or cosmetic, to a medical condition. And I do think that when we see growth failure in children, we should consider it as a medical condition rather than just a social issue. And in this situation, identified growth hormone deficiency as the cause. With the ectopic posterior pituitary gland or other organic causes of growth hormone deficiency, there are serious risks for long-term health problems, including adrenal insufficiency and metabolic complications of growth hormone deficiency. And so I think that's an important consideration that we need to evaluate and rule out significant health concerns. When we're explaining to the family the diagnostic process, we do have to talk about the growth hormone stimulation tests, the sedation for an MRI, and other things that we do that impact the potential interest in pursuing additional evaluation and the importance of having those tests done, and then talk to the family about what can we do about it. And I think one of the great things for children with growth disorders is that we have therapies available for them.
Excellent, Dr. Miller. So I presume Maya then began growth hormone treatment?
Yeah, it's interesting. Maya's parents were reluctant to think about growth hormone therapy because they were worried about having to do a shot every day in their 4-year-old daughter. They wondered about whether or not growth hormone was safe because they thought, that it might be a steroid or that it might make things grow that shouldn't. But after we talk about growth hormone deficiency with our families and talk about the importance of growth hormone replacement with growth as well as the other benefits, they agree to proceed. They have injection training by a nurse who actually came to their house. And although Maya, being 4, was afraid of getting a shot, she actually gets used to it pretty quick. And so it becomes part of their daily routine after a very short period of time.
So after being able to accept the fact that she's on growth hormone, then how do you actually plan for her to return for follow-up, and what steps do you need to take to monitor the treatment efficacy, Dr. Miller?
So I think it's important at the beginning of therapy to really establish the expectations, appropriate expectations with families of how often will they need to be seen, how often will they need to have blood tests, how much will Maya grow in the first year, and Can she stop after the first year, or will she have to keep taking it for a long time? And those are all things that families come into it not knowing and not necessarily understanding. And so they have to, initially we see patients every 3 to 4 months, and that's the ideal interval. But over time that may decrease to, every 4 to 6 months, but no less than every 6 months visits. We typically do lab tests once or twice a year. We do the annual bone age x-ray to help understand how their bones are maturing and how much time we have left to grow. We adjust the growth hormone dose based upon her weight, how she's growing, and some pediatric endocrinologists use IGF-1 values to help guide that dose to individualize the treatment.
So I'm curious, Dr. Miller, to know that once that has all been explained to the patient and expectations to the parents, how did she actually end up doing? Was she doing well after that?
Yeah, so I think we typically see the first 2 years of therapy be the best because it's the classical catch-up growth phase in children with growth hormone deficiency. So after 2 years, she's gone from almost -4 standard deviations or well below the curve to just at the bottom of the curve. And so even though we've had an excellent growth response, she's still only at the second percentile after 2 years. And Maya's mother reports, like many of my patients, that they have not missed a single dose of growth hormone since starting treatment. She's now caught up after 2 years to be this with some of her peers. Obviously, at the second percentile, she's still at the bottom of the curve for girls her age, but she's no longer the same size as her younger sister. And so you can now see the difference between the two girls.
That's so encouraging to hear. So I'm curious to know from your standpoint, Dr. Miller, that you've described it very elegantly how you would have treated Maya, but are there any clinical practice guidelines out there to help clinicians in terms of how to treat patients like Maya?
So I think the most recent clinical guidelines from the Pediatric Endocrine Society were published by Ada Grimberg and colleagues in 2016 that really outlined the dosing regimens that have the most evidence behind them, as well as the monitoring evidence and recommendations for treatment of children with pediatric growth hormone deficiency and other growth disorders. And what I've described in the previous slide or previous discussion of Maya's case was following those guidelines and reflects those guidelines in general.
And I think one of the things about treatment with growth hormone is the adherence aspect of it. What are the factors that actually might affect adherence to growth hormone therapy?
So I think, no, sorry to interrupt. No, I think it's a number of different factors impact adherence in our patient population. Disease-related things like hypertension in adults. A child with growth hormone deficiency often doesn't have very many signs or symptoms if they don't take their growth hormone. So that absence of feeling ill is one component of the disease. Patient-related, if you think about whether the patient has a good relationship with their doctor, the age or the developmental age of the patient, the understanding of the condition, and those factors are also go with the parents. Obviously, since we're treating young children, the educational level of the parents and their understanding and respect or faith in their doctor and in medicine in general can be a very important part. Treatment related, I already said that growth hormone is given by a daily injection. So if that injection hurts a lot, is difficult to prepare or mix, has to be stored in the refrigerator, reducing the ability to travel. Those can all be things that impact whether or not somebody takes their medication regularly. From a healthcare system perspective, we see challenges with insurance approval or pharmacy refill delays or expense of the medication that can sometimes delay somebody from being able to receive treatment. And lastly, how physician related, how good are we as providers in explaining all of these components to our patients, or how good is our team at doing so and answering questions to patients when they come up?
That's indeed very educational, and thank you, Dr. Miller. So, returning back to Maya, so how did she do as did she continue to grow, and how did she do being on growth hormone?
So she is a good example of somebody with severe growth hormone deficiency that even after 2 years, she continues to show catch-up growth. And so at 10 years of age, she has made it all the way up to the 20th percentile, which is actually close to her mid-parental target height, which would be about the 25th percentile. Mom reports that they occasionally miss doses of growth hormone about twice per month. And usually they're events like a sleepover or travel, but can just be routine where they were forgotten that night. But she's demonstrated a good growth response and is making consistent gains over time.
I guess only missing 2 doses a month is actually pretty impressive. And I think that also explains why she's showing good growth on her growth charts as well, right?
I would agree. And one of the challenges that we have in pediatric growth hormone deficiency is quantifying the impact of adherence on outcomes. And so there have been different studies that have shown the more doses you miss, the larger the impact on your growth, on your IGF-1 levels. But it's hard to quantify exactly centimeters per missed dose, if you will. And what we see is as kids get older, we start to see more impact on adherence, particularly when kids get to be teenagers. And so that's a difficult age for adherence with anything.
Great, yes. So Maya continues to grow at a good rate, right? And how did she do?
So as a teenager, she's comes back at 13 years of age. She's had her first menstrual period around 12 and a half, which is typical for the general population. And that for most girls is just after the peak of the pubertal growth spurt. So she's hit most of her growth and is starting to slow down now. She's had a stable growth along the same trajectory as I mentioned before, now at the 27th percentile, so very consistent with her mid-parental target height. But, she started doing her, her own injections when she was 10, and she's now 13. So when you ask Maya, she tells you she hasn't missed a dose of growth hormone since her last visit 6 months ago. But mom says, what about all of those extra vials or extra pen cartridges in the refrigerator, or the fact that I haven't had to order a refill as often? And so Maya admits that she's not taking her growth hormone when she goes to sleepovers, goes to camp, or is too tired. And so she's missing a lot more shots than she will admit. The next question that she asks is very telling, and it's, how much longer do I need to keep taking growth hormone? And that's a really common question that we get in teenagers because they feel like their growth is happening and that they're now at a height that's almost close to what they will be as an adult, and they feel like they just would like to be done. So I think it's important to continue to talk about the timing, the duration, and resetting the expectations for kids as they get older and are now able to understand them. They may still not understand the ramifications of not following through, but at least you have that ongoing conversation to say, this is something we need to keep doing.
Yeah, very interesting, Dr. Miller, to hear that she is having these issues, but which is not unusual. So I think there's a degree of treatment fatigue creeping in, which is understandable. Um, and so, what are your thoughts about adherence and the duration of growth hormone treatment? Is there any correlation at all?
No, I think there is, and it's a little bit challenging to separate the number of years of treatment with the age of the patient and the potential impact of different developmental stages. So, for example, we know that the treatment adherence decreases with the time of therapy, but it's a challenge to separate that from treatment adherence and being a teenager, for example. So I think that both are important, is how long somebody's been on treatment, but also how much have they grown? Is that growth as much as they expected, or you explained that they were likely to get? And what is their age and developmental status and sort of level of independence? I think those are all important things, but there's a definite connection between duration and reduced adherence.
So as Maya continues to grow, and she's expressed some degree of hesitation to continue with her growth hormone daily shots. So how did she do eventually?
So treatment, because she has organic growth hormone deficiency, she is likely to benefit from growth hormone therapy until she is done growing and probably beyond. And so after explaining that to her and continuing to reinforce that at each visit, she comes back at age 15 and her growth velocity has slowed to less than 2 centimeters per year, where from a linear growth perspective, we know that growth hormone isn't going to help much anymore. Her height, as I mentioned before, is at the 25th percentile. And her mother reports that she hasn't been taking the growth hormone injections for the last 2 months. Maya says she's happy with her height and doesn't think that the growth hormone injections are helping her anymore. So at this point, as I mentioned, because of the metabolic benefits of growth hormone therapy, it's important to assess her need for ongoing treatment as an adult, growth hormone replacement therapy as an adult.
So I think it's quite common that when we come to this stage in a child's life, that the question that is commonly asked is, when is the right time, the most appropriate time to stop treatment, whether the patient is overall finds it satisfied with the treatment outcomes, and if there is any tests that we should be doing when a patient has reached final height to determine if they still have persistent growth hormone deficiency in adulthood. And finally, also, I think it's also important at this stage to also assess the patient's perception and patient's interest to see whether they would consider going on to growth hormone treatment again if they should they be found to be growth hormone deficient at this stage. And I thought what was interesting, Dr. Miller, when you said that, is that I would present, perhaps maybe, or even discuss some of the common challenges when it comes to effective transitioning of a patient over to adult services from the pediatric services. And I think we can kind of break them down into three different categories. We have the patient caregivers, we have the pediatric, and then we also have the adult endocrinologist. And I think in terms of patient or caregivers, in terms of their challenges, several things that we over the years have identified would be perhaps that they could be more educated in terms of their treatment benefits and their importance and awareness of consistent injections. Patients may have lack of expectations or preparation for managing the disease as they move into adulthood. And as a result, this commonly translates over into reduction in treatment adherence. The other thing that I think patients are also wanting to know is is there any other treatment options besides injections that they can consider, like a tablet or a pill or something like that? And unfortunately, at this time, there isn't, and that may also play a role in affecting their affecting successful transition. Treatment costs also is a big issue too. These medications are indeed quite expensive, and that also is a major limiting factor. Patients may also not be directed to appropriate clinicians or pituitary centers where they are qualified and have the manpower and the pathway to seamlessly take over the care of these patients. Finally, I think there's also payers who may not cover or dictate where patients will go for their testing. And there's also some parental trust issues associated with adult endocrinologists, as they are so used with dealing with pediatric endocrinologists. I think also from the pediatric endocrinologist standpoint, there's also a lack of education of the true benefits of growth hormone therapy in adulthood. And perhaps that may translate into a reduction of effective communication of the importance of growth hormone therapy moving into adulthood. There are some practices and some places where the treatment of growth hormone deficiency for pediatric growth hormone deficient patients, when they are transferred over to adults, they may have a lack of effective model for transferring these patients over. And certainly I've also met some pediatric endocrinologists who are quite happy to keep their patients well into their adult years, and that is also a bit of a problem when adult endocrinologists find when they are trying to see these patients and convince them that they should be taking over the care, given that they're now into perhaps their late 20s or even early 30s. I think for adult endocrinologists, there's also some degree of lack of long-term benefit data of growth hormone therapy, particularly the benefits and also the safety, especially for those patients who have been diagnosed with childhood cancer, as to whether is it safe to keep these patients on long-term therapy for many years to come. And I think sometimes we've also come across some providers who may not have the ability to test these patients, or may not even offer retesting after the attainment of final height of these patients. I think these are very important points that can affect this successful transition of a patient across to from pediatric to adult services. So I think at this stage, I would like to maybe take a look at another short case to illustrate some of the issues in transitioning patients from pediatrics to adult growth hormone management. So this is a case of a patient called Ryan. He's 21 years old, and his presents with his parents to the clinic regarding growth hormone therapy. So his history is as follows. He was initially diagnosed at the age of 11, and at that time the penny dropped when his younger brother actually outgrew him. Subsequent workup confirmed that he had childhood onset craniopharyngioma, for which appropriate surgery was undertaken and resulting in him developing panhypopituitarism. He was treated with growth hormone for approximately 4 years between the age of 13 to 17, and his height increased from 15% to 90th percentile. At this point in time, he was advised by his pediatrician that you are now 5'10" in height, so you're tall enough. And in fact, Ryan was very happy to hear that, because he subsequently replied that he was actually quite tired of giving the shots to himself anyway. So he came off growth hormone as a result, and after 4 or 5 years, his mom starts to notice that Ryan was becoming more reduced in terms of his motivation. He was sitting, watching TV, and had a great appetite, and was pretty much demotivated into doing the things that he used to like to do. His father actually read about growth hormone use in adults on the internet, and subsequently was referred to the adult clinic because he was exploring the possibility of considering growth hormone in Ryan. So I think the question is, why did it take such a long time, in Ryan's case, 4 years, for him to transition over from pediatric to adult services and to be at least tested and subsequently considered for growth hormone replacement? I think there were several reasons in Ryan's case. Firstly was the fact that his pediatric endo, when he referred Ryan to the adult endocrinology practice, he did mention to Ryan, which was a little off-putting to Ryan, when he said that I'll see you in the waiting room until the babies get embarrassing for you. So he felt a little awkward coming to see his pediatric endocrinologist as a result, because he felt that he had outgrown the practice. And so several appointments were made for Ryan, but as a result, he was in a dilemma. He didn't really follow up with his appointments, and so subsequently he missed his appointments. I think the other thing that Ryan also experienced was the fact that he perhaps was so used to and was so comfortable with his pediatric endocrinologist that he felt uncomfortable, or maybe there's a degree of anxiety as well when he began a new relationship with an adult endocrinologist. So that may have also been a factor as well. And so as a result, Ryan was actually lost in follow-up between both the pediatric and the adult practice. Eventually, after much convincing by his dad, who actually read about growth hormone use in adults, he decided it was time to try out a new adult endocrinologist closer to home. But again, he was told that he did not need growth hormone because adults at that time, according to this adult endocrinologist, did not really need growth hormone because he had already grown to his final height. So Dr. Miller, as a pediatric endocrinologist, what is your experience about discussing and setting expectations to your patients early on about growth hormone treatment when you first see them?
So I've tried to do that quite deliberately with my patients so that they're not blindsided by the fact that they may need to take growth hormone as an adult. And I start discussing it at the beginning of therapy, but also at key developmental milestones for the patients. But even so, as you mentioned, we tend to hold on to our patients a little bit longer. And so I've tended to try and have my patients be already diagnosed with retesting performed with a diagnosis of adult growth hormone deficiency before making that transition, because of my concern that some adult endocrinology practices don't have the capacity to do that testing. But I think that may end up leading to perpetuating the pediatric care rather than helping them transition earlier and become more independent early on. So I think that's something that we as pediatric endocrinologists need to do a little bit more proactively, of getting the patient involved in their own care and making those decisions sooner so that they're ready to make that transition when it's time. And then finding the right time for that family and that patient. Some of our patients are cancer survivors, as you mentioned, who may have significant health and social needs and may not be able to be independent. And so some of those patients can be more challenging to transition. I think it's important for us to identify the people in our community that are the adult experts in growth hormone deficiency so that we can have that handoff.
Great. Thank you, Dr. Miller, for your insight into this topic. So I think there are some guidelines that are published recently of how effective transition can take place. And clearly, it starts off with the pediatric care, where the patient, as you had alluded to, Dr. Miller, about performing the stimulation testing before considering transitioning them over. And from the adult standpoint, either the adult endocrinologist or even the pediatric endocrinologist could take the lead in completing the testing if they have sufficient facilities or the bandwidth to perform this test, or depending on the comfort level and the accessibility of these tests. But certainly during this crucial period, communication is crucial between pediatric and adult care providers. And I think once the diagnosis has been made after performing the growth hormone stimulation testing, then I think further education needs to be imparted as well to the patient. And I think depending on where the patient is, whether be it after being tested by a pediatric endocrinologist or by an adult endocrinologist, I think the education needs to then be performed or be imparted to the patient as to the benefits and the reasoning behind and the justification of continuing growth hormone treatment moving into adulthood. And the American Association of Clinical Endocrinology in 2019 published in the Endocrine Practice have a nice algorithm to guide clinicians to how the testing should be performed, depending on the clinical suspicion and the number of pituitary hormonal deficiencies that would guide the clinician to consider performing growth hormone stimulation tests or not. And certainly there are some exceptions where growth hormone stimulation testing is not required, particularly in those who have had 3 or more pituitary hormonal deficiencies and low IGF-1, or those who have genetic defect or congenital defects. But otherwise, by and large, most patients do require growth hormone stimulation testing at the end of during the transition period to determine if they truly have growth hormone deficiency or not moving into adulthood.
So Dr. Yuan, tell me more about Ryan and how he did.
Yes, so what Ryan did was when he was seen at the adult endocrinology department, he was tested and his IGF-1 came back as very low at 74 nanograms per ml, with the reference range being 182 to 780 nanograms per ml. He also had other pituitary hormonal deficiencies, at least 3 of them. So clearly he was pan-hypopituitary, but also with growth hormone deficiency moving forward. And Ryan then became more interested because now he knows that the importance of growth hormone, and he's been doing some extra reading, and he now would like to consider growth hormone because he found out that it does help improve his body composition, perhaps also has some improvement in his mental function, and certainly moving forward as he gets older, cardiovascular risk and bone effects are also important things to consider in an adult. So he was started at an adult dose, and based on his gender, and his dose was titrated at a dose of 1 milligram a day, and his dose was titrated according to the IGF-1 levels up to almost 500 nanograms per ml, and that actually helped him a lot in terms of his energy levels and his mental function. So eventually, over 2 or 3 years, his body composition improved. His bone mineral density was also noted to be in good shape. He was able to have energy and also was more motivated, and started playing sports regularly and was coming to the clinic, this time unaccompanied by his parents. And in fact, he was so interested that he also raised the question about whether he could be considered for a long-acting growth hormone preparation.
So, Dr. Ewan, one question about Ryan is, did his history of craniopharyngioma have any impact on his interest or fears about being on growth hormone?
He did raise the question that given that if he was to continue on growth hormone as an adult, that he would end up taking growth hormone for many years. And certainly the expectation was raised that if you go on growth hormone and continue on growth hormone, it would be for long term. So he raised the question of whether being on growth hormone for that many years would cause the craniopharyngioma tumor to grow back. And certainly that is a very, very valid question that we encounter as adult endocrinologists. Fortunately, looking at the data that has been published in the last 10, 15 years in the literature, there hasn't been any red flags to indicate that a long-term growth hormone replacement causes tumor regrowth, particularly in craniopharyngioma patients. But obviously, this has to be done, the dosing has to be done in a careful manner, that you adjust the dose accordingly to the IGF-1 levels and not to titrate the dose to exceed the IGF-1 levels above the reference range. And so the data is based on this. So I think the safety data is very convincing, and I think that also helped the decision-making easier for Ryan, for him to consider growth hormone moving forward.
So you mentioned that he's participating in a long-acting growth hormone study. So tell me a little bit more about how we make an injection of growth hormone last longer.
Yeah, so growth hormone is a molecule that is made up of 191 amino acids. And physiologically, we know growth hormone is produced in a very pulsatile manner. It typically rises in the early hours of the morning when one is asleep, and then gradually declines as the day progresses, so that it eventually peters out during the time when the person goes to bed. And so that the production of growth hormone is designed in a way that it doesn't last for very long. And that's why the body very naturally produces growth hormone in a very pulsatile way every day, over a 24-hour period. So there have been several new technologies that have been studied in the last 10 to 15 years, looking at increasing the duration of growth hormone preparations. And one way is either to delay the rate of absorption from the subcutaneous space by incorporating the growth hormone molecule into microspheres. The other way is to reduce the clearance of the growth hormone molecule from the circulation. And this can be done in a number of ways, either by pegylating the molecule, or by modifying the binding protein of the growth hormone to serum proteins in the circulation, like, for example, changing the binding of the growth hormone to incorporate that molecule to an albumin molecule in the circulation. And also, finally, there's also fusion proteins, which basically means that there are proteins that are attached to the growth hormone. They could be synthetic polypeptides, or they could be naturally occurring proteins like human chorionic gonadotrophins, albumin, and growth hormone binding proteins. And these proteins, when you attach themselves, or when you attach them to the hormone, actually can prolong the action of growth hormone.
All right. So there have been a number of long-acting growth hormone preparations that were representative of the depot formulation. And the one that people may remember the most is Neutropin Depot, which encapsulated growth hormone into biodegradable spheres, microspheres. But unfortunately, because of lack of efficacy and pain associated with the medication, as well as manufacturing issues, it was ultimately removed from the market. Currently, the one that most closely resembles a depot using microparticles incorporated into sodium hyaluronate is Utropin Plus, which is currently marketed in Korea for pediatric growth hormone deficiency.
And there's also another form of long-acting growth hormone preparation, which is the Pegylated formulation. And in this class of preparations, I think one of the compounds that is known really is the Jintrolong product, which has been marketed in China now for childhood growth hormone deficiency and has undergone phase 3 studies showing very good IGF-1 profile. And there are further studies that are now ongoing for this compound as well. There are other compounds as well, but unfortunately, some of the compounds that were studied did not make it through simply because they failed to meet the endpoints designated for these compounds during the studies, and as a result, they were discontinued.
The next one that I'll talk about is the example of the non-covalent albumin binding molecule. And the best example of that is somapacitan, which has been commercially named Sogroya, which is a growth hormone with a single point mutation to attach an albumin binding moiety. And this drug has completed phase 3 studies in adults and was approved by the FDA in August of 2020, but is not yet commercially available and is currently in studies for SGA as well as pediatric growth hormone deficiency. And we're expecting the results of those trials sometime in 2022.
Yeah, indeed. We're looking forward to those data.
Yes.
And the next class is a prodrug formulation, and the best example is the TransCon growth hormone, or it's also named Skytrofa. It is an unmodified growth hormone that is transiently bound to a pegylated carrier molecule via a self-cleaving linker that is dependent upon the pH and temperature. And this is a very interesting compound, and in fact, has done very well in phase 2 studies in childhood growth hormone deficiency, showing comparable growth hormone and IGF-1 profiles to daily growth hormone dosing. And in fact, in the recent phase 3 study, showed very nice positive growth response in childhood growth hormone deficient patients. And because of the completion and the excellent data shown in these studies, that the data was submitted and subsequently has been approved for use by the FDA for childhood growth hormone deficient patients, and also recently has also been approved in Europe as well. And so currently there are phase 3 studies ongoing in adults with growth hormone deficiency that are currently being undertaken.
And the last group that I'd like to discuss are the growth hormone fusion proteins. There have been a number of attempts in this area with once weekly, once every 2 weeks, or once monthly. And the one that is most close to use in children is somatrogon, which is a growth hormone modified by attaching 3 cartridges of the C-terminal peptide of human chorionic gonadotropin to the growth hormone molecule, thereby decreasing its clearance from the circulation. This drug has recently completed the phase 3 clinical trials and is awaiting review by the FDA for approval in the US. It was recently approved in Australia and in Canada, and received a favorable report from the European agencies, but is still pending approval there. The adult trials of somatrogon, the phase 3 trial, actually missed its clinical endpoint, and it remains to be seen as to whether this will be retested or restudied in adults. So now I'll give a little bit of the data from those clinical trials that we talked about for the different long-acting growth hormones. And beginning with somapacitan, this drug has been studied in phase 2, where children received 0.16 milligram per kilogram per week and were compared to daily growth hormone at a dose of 0.034 milligrams per kilogram per week. And the results of the trial showed that the IGF-1 levels at peak were above average, approximately +1 standard deviation in the highest dose, 0.16 milligram per kilogram per week. But when we look at a model-derived average, they were about +0.5 standard deviations, whereas in the daily group, they were at the mean. So daily growth hormone achieved a mean IGF-1 of 0 standard deviation scores. So we can see that somapacitan, in addition to achieving improved growth, achieved increased IGF-1 levels slightly compared to daily growth hormone therapy. When we look at somatrogon, the clinical phase 3 trial showed that children receiving 0.66 milligrams per kilogram per week of somatrogon had a superior growth velocity of 10.12 centimeters per year compared to the genotropin group of 9.78 centimeters per year. This was not statistically significant, but the safety and tolerability of somatrogon were similar between daily and somatrogon. And then lastly, lonopeg somatropin, now commercially named Skytrofa, showed excellent clinical response in phase 3 height data, but also in the switch trial where children receiving daily growth hormone switched to weekly growth hormone with lonopeg somatropin, we could see a continued growth response in these children. And this trial also included some very young children, leading to the approval of the drug down to 1 year of age. So I think it's an important that we recognize growth hormone deficiency in the younger children can be treated by a long-acting growth hormone, but it'll be necessary to know whether or not they're having hypoglycemia, because it's the one area that a long-acting growth hormone therapy may not be beneficial if growth hormone treatment is reducing the possibility of symptomatic hypoglycemia. When you hit the trough with a long-acting growth hormone therapy, there may actually be an increased risk for growth hormone deficiency-related hypoglycemia, suggesting that those patients might not benefit from a long-acting drug.
Indeed, Dr. Miller, there's still a lot of questions pertaining to the use of long-acting growth hormone. And in fact, I think we could perhaps think of a few as well, because I think it's important for potential providers who are considering growth hormone to keep this in mind. For example, long-acting growth hormone, can it cause tachyphylaxis or downregulate growth hormone receptors? Will the effects of long-acting growth hormone preparations be durable, especially when used over a long-term period? Can long-acting preparations with larger molecular sizes compared to the native growth hormone, can they penetrate all tissues equally and exert their effects equally? And that's certainly very important that we still need further data on. What about the long-term metabolic consequences? And Dr. Miller, I guess you mentioned that as well with long-term growth, long-acting growth hormone preparations. Not only in children, but also in adults as well. Will it potentially can it cause diabetes as well? When's the best time to measure IGF-1 levels, given that the injections are typically given once a week? And is it the same for all long-acting preparations? We still don't know the answer to that. How to start and adjust long-acting growth hormone preparation in terms of their dosing. and also whether is it the same for different preparations is certainly something we still need to know more. Is long-acting growth hormone preparations cost-effective, and will they truly improve adherence and outcomes? I think further studies are still needed. And what about childhood cancer survivors? Are they safe to be used in adulthood over long term? And finally, I think the other question is the side effect profile of the long-acting preparation. Are they comparable or are they different to the daily growth hormone preparation, given that the long-acting growth hormone preparations are different in terms of their molecular structure from one brand to another? So I think there's still a lot of questions that needs to be answered with long-acting growth hormone preparations for now.
I agree, and I think that it's going to be important that we study those as long-acting growth hormone becomes available and in use in our patient population, that we conduct safety studies, whether that's in the form of a formal registry or I'm working with an international group to develop a global registry for pediatric growth hormone deficiency so that we can help collect that information, not just in the short term, but to be able to continue to do so long term. I think that's going to be important of what that real world evidence looks like.
Very true indeed. Also for adults too, especially the childhood cancer survivors as they move into adulthood, and more of these patients are surviving into adulthood. So certainly very important. I agree with you, Dr. Miller.
Absolutely.
So, well, we are just about out of time. So by the way of summary, I'd like to offer a few SMART goals, which are specific, measurable, attainable, relevant, and timely action items for clinicians to take back to your practice. So firstly is to identify and assess pediatric patients with possible growth hormone deficiency and refer these patients to an experienced pediatric endocrinologist as appropriate. Number two, communicate with families and providers, for example, primary care and specialists throughout the treatment journey of each patient. Number three, begin each patient with early discussions of continuation of growth hormone replacement into adulthood to minimize interruptions of therapy during transition period. And finally, to keep current with new developments and approvals in long-acting growth hormone preparations. I would like to thank you, Dr. Miller, for an insightful discussion today. And thank you to our audience for joining us. I hope this information will be helpful to you in your clinical practice. Stay safe, everyone, and thank you again for participating in this program.